Imagine your brain suddenly convincing you that if you don't delete and retype the sentence you just wrote exactly 7 times, you're going to lose your job.
Right?
Like, the fear is visceral, it feels entirely real, and your heart is just pounding. Now, imagine trying to express that paralyzing fear to a coworker, and they just smile and tell you they totally get it because they just have to keep their desk perfectly
Oh,
organized.
yeah. It is a completely jarring disconnect. And yet, I mean, that exact disconnect has thoroughly permeated our everyday language.
It really has. So today we are taking a deep dive into this incredible stack of clinical materials and telehealth practice data that you, our listener, sent in.
Yeah, and it's such vital material to cover.
Exactly. And our mission today is very clear. We are going to completely dismantle the everyday colloquial myths surrounding obsessive-compulsive disorder. We need to look at the genuinely tormenting reality of what this disorder actually does to a human brain. And then, explore how modern specialized telehealth is fundamentally changing who gets access to the cure.
Right, because understanding the actual precise clinical definition is the absolute crucial first step here. As long as we treat the term like some quirky personality trait, we're doing a massive disservice to the millions of people who are paying a devastating functional cost every single day.
Yeah. Looking at these clinical definitions you shared, it instantly made me think of a comparison. Using the term OCD just because you prefer a tidy workspace is essentially like claiming you have a debilitating neurological migraine just because you bumped your head on a kitchen cabinet.
That's a great way to put it.
Right. It takes a severe, complex medical condition and just reduces it to a minor, everyday preference. It completely erases the reality of the pathology.
And the gap between a preference and a pathology is enormous. I mean, a preference is something that brings you satisfaction or order. A pathology is something that strips away your agency.
Wow. Strips away your agency.
Yeah. To really understand why that casual use is so wildly inaccurate, we have to look at the two inextricably linked components that define the disorder: obsessions and compulsions.
Okay, let's unpack this.
So, obsessions are intrusive, distressing thoughts, images, or urges. They are not desires. And compulsions are the repetitive behaviors or mental rituals that the person feels fiercely driven to perform to neutralize the terror of those obsessions.
Okay, let's unpack this because the diagnostic metric required to actually be diagnosed with OCD really stopped me in my tracks.
Yeah, at the time thresholds.
Exactly. The clinical threshold states that these thoughts and behaviors have to consume 1 or more hours of the individual's day and cause significant suffering.
Right.
But I'm trying to visualize what that actually looks like. Is that 1 hour all at once? Like you sit down for 60 minutes, lock the door, and perform a ritual? Or is this more of a constant, exhausting drip, drip, drip of anxiety throughout the entire day?
It is almost always that agonizing drip, 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 drip.
Oh, really?
Yeah. I mean, while someone might occasionally have a contiguous block of time, say a highly ritualized hour-long showering process, more often it's insidious. It's 5 minutes here, 10 minutes
It's
there.
just constantly interrupting your life.
Exactly. It's a mental ritual performed while you're desperately trying to focus on a meeting. It's a physical check of a door lock that takes 3 minutes, but happens 20 times before you can even leave for work.
That sounds exhausting.
It fragments a person's attention so completely that their cognitive energy is just drained continuously from the moment they wake up.
Which brings up a massive contrast. The casual use is usually, I want to keep things tidy. The internal monologue is driven by a desire for order, but true compulsivity is driven by profound terror.
Yes.
The internal monologue is, if I don't do this exactly right, something terrible will happen.
What's fascinating here is the underlying psychological mechanism that creates that terror. These obsessions are what clinical psychology calls ego dystonic.
Ego dystonic. Wait, let's break that down because it sounds incredibly intense. What does that actually mean?
Well, ego dystonic means these intrusive thoughts feel completely foreign, alien, and fundamentally unwanted to the person experiencing them.
Unwanted, so they hate the thoughts.
Exactly. They directly conflict with the person's actual values, beliefs, and core desires. If you are someone who deeply loves your family, an ego-dystonic obsession might be a sudden flashing image of harming them.
Oh, wow. That's
You
horrifying.
do not want to do it. The thought absolutely horrifies you, but your brain's alarm system misfires and serves up the image anyway, accompanied by a massive spike of adrenaline.
Wait, if the thought is so horrific to the person, why would they perform a compulsion? Doesn't doing a ritual kind of validate the thought in their head?
Logically, yes, but OCD does not operate on logic. It operates on fear.
Right.
The brain is screaming that the threat is real. The compulsion is simply a desperate, immediate attempt to neutralize that horrifying thought and make the anxiety stop. It is a survival mechanism gone entirely wrong.
That completely reframes the entire experience for me. I mean, if these thoughts attack the exact things you care about most, then this goes so far beyond the cultural stereotype of just washing hands or lighting up pencils.
Absolutely. Hand washing is just one visible compulsion tied to one specific theme, which is contamination. But the reality of the disorder is vastly more diverse and insidious.
Yeah, I noticed in the clinical breakdown there are specific themes of OCD that most people have probably never even heard of.
Oh, for sure.
Contamination and harm are listed, but then there is scrupulosity. How does that actually manifest?
So scrupulosity involves religious or moral obsessions. A person might be tortured by the idea that they accidentally committed a sin or violated a deeply held moral code or, thought a blasphemous word.
So they're just consumed by guilt over something they didn't even want to do.
Right. And the compulsion might involve praying for hours on end, not out of spiritual devotion, but out of sheer terror that they will be condemned if they don't say the prayer with absolute, perfect precision.
Man, that sounds exhausting. And another one mentioned is relationship OCD,
Yes, that's a tough one.
where someone is obsessively doubting if their partner is the one, right? Analyzing every micro-expression their partner makes to prove the relationship isn't doomed.
Exactly.
But the one that I found hardest to conceptualize at first was the just right feeling. What is that?
It is notoriously difficult for people without OCD to grasp because it lacks a clear, rational consequence. It's just a vague sense of impending doom.
I was trying to figure out an analogy for it. Is it kind of like when you are typing a highly sensitive email to your boss and your brain suddenly convinces you that if you don't backspace and retype the very last sentence perfectly,
Yes.
like hitting the keys with the exact right amount of pressure, the whole message is inherently wrong. And by extension, your whole career is doomed. So you just sit there deleting and retyping it over and over again.
Yes. And what is happening neurologically when you sit there deleting that email is a systemic hijacking of your innate sense of completion.
The hijacking.
Right. The mechanism in the brain that normally sends a signal saying, task finished, you can move on now, is broken. It's a malfunction of the brain's alarm system, the amygdala.
So the amygdala is basically ringing the fire alarm when there's no smoke.
Exactly. The amygdala usually warns us of actual danger, like a physical predator. In OCD, it rings at a deafening volume over things that pose zero actual threat. The diverse themes just reflect whatever subject the person's malfunctioning alarm system has decided to latch onto.
So if this disorder is this specific and the torment is this severe, then how is the medical system missing it? Because the statistics on the diagnostic gap are frankly terrifying.
They really are.
The source says OCD is misidentified in approximately half of all presenting cases, 50%.
You have, yes.
And it says the most common mistake is that it gets falsely labeled as generalized anxiety.
If we connect this to the bigger picture,
Mm.
you have to look at how patients present in a clinical setting.
But I'm genuinely confused by that 50% failure rate. I mean, if a patient walks into a clinic terrified, crying, saying, I am constantly worried about getting into a car crash, wouldn't a doctor naturally assume that is generalized anxiety? How are they supposed to instantly spot the difference?
Well, because clinicians are largely trained to spot the symptom of anxiety, but they often fail to ask the critical follow-up question,
Which is?
the behavioral loop. The difference between generalized anxiety and OCD lies entirely in that behavior loop. A person with generalized anxiety worries constantly about a car crash. A person with OCD worries about a car crash and then feels an unbearable urge to tap their steering wheel exactly 7 times before turning the ignition to magically prevent the crash.
Ah, okay. So the generalized anxiety is just the emotional feeling of dread, but OCD is the dread plus the forced ritualistic action.
Precisely. If a clinician only hears about the worry and does not specifically ask, what behaviors or mental routines do you perform to make that worry go away, they will default to a generalized anxiety diagnosis.
And that leads to a totally wrong treatment path.
A catastrophic outcome, really.
Yeah.
Untreated OCD tends not to remit spontaneously. You do not just outgrow it or sleep it off. Without the correct diagnosis, a patient is prescribed standard talk therapy or generalized anxiety medication, which does almost nothing for the compulsive loop. They're left fighting the wrong battle entirely.
Which means they remain trapped. The functional cost of that is massive. I mean, we're talking destroyed careers, isolated relationships, people who physically cannot leave their homes.
It's heartbreaking.
But that leads us directly into the mechanics of the actual cure. Since we know generic therapy misses the mark, what does rewiring an OCD brain actually require?
It requires an incredibly specific, evidence-based approach called exposure and response prevention, or ERP, and that is very often paired with specialized medication management.
Right, and the clinical details are very firm on this. ERP is explicitly not standard talk therapy. You aren't lying on a couch exploring your childhood trauma or venting about your week.
No, not at all.
But here's where it gets really interesting to me. Trying to figure out how ERP differs from generic therapy. It seems like generic therapy is like sitting safely on the beach with the therapist, talking about your intense fear of drowning and analyzing why you might be afraid of the water.
Sure.
But ERP is totally different. ERP is basically having a trained guide walk you right into the freezing shallow end of the pool and forcing you to stand there in the cold water without letting you run back to your towel.
That captures the mechanical reality of it perfectly. It's about physical and psychological endurance.
That sounds terrifying.
It is. Let's look at why that's neurologically necessary. When an OCD patient touches a contaminated doorknob, their brain screams that they are in mortal peril. The urge to perform the compulsion to wash their hands is as overwhelming as the urge to breathe when you're held underwater.
So they literally feel like they're going to die.
Yes. ERP demands that the patient touch the doorknob, trigger that terrifying "I am going to die" feeling, and then purposefully choose to do nothing.
That sounds like torture. How does the brain ever recover from that?
Through a process called habituation.
Habituation.
By sitting in the anxiety and resisting the compulsion, the patient forces the brain to experience the fact that the perceived catastrophe never actually happens. Slowly, session by session, the malfunctioning amygdala learns that the alarm was false.
So the volume of the fear just turns down.
Exactly, the volume turns down, but the sheer mental endurance required to reach that point is staggering.
Which brings us to the medication side of things. The source mentions that when SSRIs, selective serotonin reuptake inhibitors, are prescribed for OCD, they're often given at much higher doses than they are for standard depression.
That's right.
Why is that? I mean, why does OCD need such a massive dose of serotonin compared to depression?
Because the brain is essentially locked in a rigid, repetitive loop. Higher doses of SSRIs flood the system with serotonin, which acts almost like a neurological lubricant.
A neurological lubricant. I like that.
Yeah, it facilitates what we call cognitive flexibility. It gives the brain just enough neuroplasticity, just enough breathing room to actually tolerate the intense discomfort of ERP without immediately shutting down or panicking.
So the meds don't just magically cure it.
No, not at all. The medication does not cure the OCD. It creates the chemical environment necessary for the patient to endure the heavy lifting of the therapy.
But having this highly specialized gold standard treatment is only actually helpful if a patient can access it.
Exactly.
And this is exactly where the structural, real-world friction of healthcare collides with the reality of living with this disorder.
This raises an important question about how we fundamentally deliver mental health care. Because, the logistics of access are often the single biggest barrier to recovery.
Seriously.
Yeah.
If you think about the landscape of mental health, finding an out-of-pocket, highly specialized therapist who is genuinely trained in strict ERP protocols is incredibly difficult.
There.
And when you do find them, it is wildly cost prohibitive. We are talking $200, sometimes $300 an hour. If you need weekly sessions, that is just financially impossible for most families.
Exactly. And the geographic barriers compound the financial ones. If you live in a dense urban center, you might have a handful of specialists to choose from. But if you live in a sprawling rural area, the chances of finding a local clinician trained to spot that 50% misdiagnosis rate, let alone perform rigorous ERP, are practically zero.
Which is why the telehealth model detailed in the data you provided is so disruptive. The listener brought us an incredible case study. Coping and Healing Counseling, or CHC.
Right.
This is a practice operating in Georgia that was fundamentally designed to obliterate both of those massive barriers, the geography and the cost.
A statewide telehealth model changes the entire equation of who gets to recover.
Completely. First of all, they serve all 159 counties in Georgia via a 100% telehealth, fully IPA-compliant model.
Which solves the geography issue immediately.
Right. And they have a diverse, Culturally competent team of over 15 licensed therapists. We're talking licensed clinical social workers, licensed professional counselors, licensed marriage and family therapists. And they treat everything from teens starting at age 13 to individuals, couples, and families.
And by covering specialties like anxiety, depression, trauma, PTSD, grief, and stress, they are capturing a massive swath of the population that might be slipping through the cracks of that misdiagnosis gap we talked about.
But here's the part that is a true game changer, the financial friction. For CHC, Medicaid patients have a $0 copay. $0.
Wow.
And for major commercial insurances, they take Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana. The cost ranges from just $10 to $40 a session. I mean, that is the difference between life and death for someone whose OCD has cost them their livelihood.
Oh, absolutely. When you remove the friction of driving 2 hours to a clinic and you remove the barrier of a $200 out-of-pocket fee, you allow the patient to actually focus their energy on the grueling work of ERP and recovery. It brings evidence-based care directly into the living rooms of the underserved.
For anyone in Georgia who might be listening and recognizing themselves in this drip, drip, drip of anxiety, CHC is incredibly accessible. Their phone number is 404-832-0102. Their website is cheatf2therapy.com, and you can email them directly at support@ft-therapy.com. It's really rare that we see a structural solution so neatly address the clinical crisis we've been breaking down today.
It is a profound shift. It proves that the torment of this disorder is highly treatable, provided the medical infrastructure is actually built to reach the patient.
So what does this all mean? If we look at the entire journey we have taken today, we started by tearing down the toxic, casual myth that OCD is just about liking a neat desk.
Okay.
We dove into the deep neurological torment of ego-dystonic thoughts, exploring how the brain's alarm system gets entirely hijacked. We uncovered the tragic reality that half of the medical system misdiagnoses this as generalized anxiety because they literally just forget to ask about the compulsions.
The behavior loop. Yep.
We broke down the intense, freezing water endurance of exposure and response prevention therapy. And finally, we saw how innovative telehealth models like CHC are actively destroying the financial and geographic walls that keep people suffering in silence.
It highlights a narrative of immense clinical hope. I mean, the brain can be rewired. The suffering does not have to be permanent.
It really doesn't. And as we wrap up today, I want to leave you, our listener, with a final lingering thought to mull over on your own. We know that clinicians are misdiagnosing this disorder 50% of the time. But we have to ask ourselves, how much of that clinical failure is actually being driven by our culture's casual misuse of the term?
That's a great point. Language shapes reality.
Exactly. When we constantly joke about being so OCD over a color-coded calendar or perfectly folded laundry, are we accidentally creating a massive cultural smokescreen? Does the joke make the word so completely meaningless that it actively prevents teachers, doctors, and even our own families from recognizing the very real, silent, agonizing torment happening right in front of them?
It is a critical question about the unintended harm of our everyday vocabulary.
It really makes you pause before you throw the term around at the office. We want to warmly thank you for bringing these vital, highly illuminating sources to today's deep dive. It is because of your curiosity that we get to break down these complex mechanisms and shed light on these realities. Keep questioning your assumptions, keep seeking out multiple perspectives, and we will see you on the next deep dive.